Good morning, everybody. Happy Friday. My name is Connor Collins. I am a registered massage therapist and sports injury therapist, and welcome to the Concast, a podcast where we discuss all things health, wellness, and injuries in an attempt to better understand the human body. This is episode number 69, where I had the pleasure of interviewing Jocelyn Kirkton. Jocelyn is a massage therapist practicing in Victoria, British Columbia in Canada. And Jocelyn's practice is centered around male pelvic health. So during this interview, we had a great conversation around pelvic health in general, persistent pelvic pain, and some of the strategies, research, and information that's out there for either yourselves as therapists or if you're a patient struggling with persistent pelvic pain on how to better manage the issues that you have moving forward and getting you back to doing all of the things that you love doing. So I definitely learned a lot in this interview. So sit back, relax, and enjoy. Okay, good morning, everybody. Welcome back to the Concast. Happy Friday to you. We've got another great interview this morning talking about a really popular and kind of emerging topic in healthcare, as well as our industry, the manual therapy and rehabilitative industry. And that is the topic of pelvic health and pelvic pain and persistent pelvic pain and issues. And I'm sure our guest today will help kind of unpack that and define it a little bit more. And really looking forward to today's conversation. I think we're going to be covering a lot of topics that aren't discussed a lot. And again, looking at how either you as a therapist can better navigate your own practice if this is an area of special interest for you, or if you're a patient and you're trying to navigate the healthcare system, maybe you might learn a few tips on how to get some answers for yourself. So Jocelyn Kirkton, welcome to the show. Looking forward to today.
Oh, thanks for having me. I'm really excited. Like I was talking about before, this is my first time doing a podcast. So I'm really, really thankful that you've included me and that you're giving me a little bit of a platform to kind of talk about an area I'm really passionate about.
Yeah, I think that, as I said, this area is, somewhat emerging and a topic that not a lot of people in our community are talking about, especially in the massage therapy community. So I think there's going to be a lot of value for people that are listening today. Jocelyn, just before we get into the topic, maybe talk a little bit about how long you've been in practice, what got you to where you are today. You can be as short or as long as you want, and then sort of how your practice is laid out and some of the patients that you're seeing in your current practice.
Yeah, absolutely. So much like everything in my practice and where I am professionally, was kind of all by accident. So I got into massage right out of high school, and it was all because I misclicked a box where to send my transcripts to. And so I misclicked University of Waterloo for West Coast College of Massage Therapy. And and then 3 months after I graduated high school, I got a letter in the mail. And the same day I found out that it was an avionic technology program at BCIT I was going to take. It got canceled because of not enough interest. The same day I got the letter to the Massage Therapy College to come check out their program. And I figured, it's massage. I wanted a career that used my hands. And I figured I'll just do this. And then I can use this as a way to pay through school, like avionics school. So I got into massage, and I just kind of by accident, and I fell in love with it from the get-go. So that was kind of my introduction into massage therapy. I never had a massage prior to massage therapy college. So in our entrance essays, when we had to write about an experience, I had to use my mom's because I didn't have one. And then when I got into practice, I didn't realize at the time I was actually seeing a lot of persistent pain. And I think for most of us, we go on this holy grail quest to try to find the modality that's going to fix people. And for me, that was visceral manipulation. I was seeing a lot of persistent lower back pain, and I figured, maybe someone's kidneys or liver or something was malaligned and needed fixing. And so I underwent 2 years, or it was almost, 2.5 years of visceral manipulation training through the Brawl Institute and through a local osteopath. And then I think for some of us, I had that moment of reading the evidence and realizing that some of the narratives that are taught just weren't supportive. And that kind of shifted me into like the pain science literature. So with my background in visceral manipulation, which I'm still very thankful for, that kind of opened the door for me to explore some of the pelvic pain populations. And the clinic I was working in up until I left to live in Victoria, prior to Victoria, I worked in Surrey, British Columbia. I worked in a clinic that was largely kind of prenatal, postpartum care. And so I got my foot in the door with pelvic pain and pelvic health because the more complicated cases would get referred to me. And through those individuals, through the women that were under my care, they would always ask me, "Oh, do you treat men too? Or is it just women?" And I thought, oh, this is a really unique opportunity for me to get in the door with male pelvic health and men's health. And so I took it on, and it's been a really, really fantastic journey. And I've learned so much with the people that I've interacted with and that have come to me for help. And now where I work in Victoria, my practice is exploding with male pelvic health. And this is a good time to talk about this population and bring some awareness to a community that is really struggling with this issue and the role that massage therapists, the important role that we play in helping people manage their pain there. So that's kind of where I am.
That sounds really great. So it seems like one of the questions that I was going to ask you was, how did you get into this? And it seems like a combination of an opportunity, and then you just kind of developed your niche out of that opportunity. So before we get into the topic, maybe Jocelyn, I'll get you to define a little bit, or try and define what we're going to try and unpack today when we maybe talk about the topic of, and I don't know if it's better to refer to it all as pelvic health or pelvic pain or persistent pelvic pain, or whether there's a few different umbrella terms that you use. But if we could just maybe give the listeners a definition of what we're going to be talking about.
So before we begin, I would just like to take the time to outline some terminology that I'll be using in the podcast today. Unfortunately, in the world of pelvic health, the research holds gender biases in that it is largely reflective of cisgendered populations. So the language I'll be using in the context of men and women in this podcast today is in the context of cisgendered males and females. And this is the language that is used in the literature. It is not language that is reflective of my views. It is only there to provide some consistency when we talk about the research and the research applied to clinical practice. You will, however, hear me say phrases like women's female pelvic health and men's male pelvic health. And by separating the women from female and the men from male, this is my way of including the LGBTQIA2S+ population in these important conversations. Everyone has a pelvis, and that pelvis may have biological female or male structures that deserve attention from healthcare providers. So I'm going to probably be using pelvic health, persistent pelvic pain kind of interchangeably, just because the umbrella of symptoms experienced is vast. So just using those umbrella terms is just going to help kind of talk generally about what's going on. And then when we talk about specific conditions, I'll name them, and then I'll give a little bit of a definition as a preface for those of you who maybe aren't familiar with conditions that affect the area.
Okay, cool. So right now in your practice, as it's continued to grow, it seems like when you were growing it, it was coming from a lot of that kind of postpartum, I guess, postpartum population. And then as you started to grow the male pelvic health side of things, I guess my question is now, are the majority of your referrals through word of mouth, or are you now working in a pelvic health clinic, or are GPs referring, or urology, gynecology, all of them?
All the above. Yep. So I started working at Tall Tree Integrative Health here in Victoria, and it's a big multidisciplinary clinic. And so I work with a fantastic pelvic floor physiotherapist, and her and our messaging is very similar. We both approach pelvic health concerns from a biopsychosocial and interpersonal framework and understanding. We have referrals from doctors, gynecologists, urologists, and then even from within the clinic as well, because we're a clinic of 35 clinicians.
Oh,
So
wow.
yeah, I get lots of referrals kind of from all the above. So.
And would you be the only RMT that sort of has that special interest within the clinic, or are there a few of you?
I think I'm the only one that has that just pelvic health umbrella term. I'll treat anyone who is experiencing any kind of pelvic concern or any kind of pelvic pain. There are a handful of RMTs that just specifically have that prenatal postpartum focus, which I feel like is very common within our profession.
Mm-hmm.
So it's kind of like same but different.
Mm-hmm. What percentage of your practice would you say right now is that?
Just pelvic?
Yeah.
Upwards of probably 70% right now.
Wow. So that's a lot. So it's clearly something that's in high demand for patients to be able to manage. Is there a common demographic of people that you're seeing, either a specific age, or you mentioned some of the perinatal, postnatal stuff? If you think about it, is there a demographic that you feel like this happens to more?
In terms of experiencing concerns or?
Yeah, concerns, or is it just you're seeing everything?
The unique population I see right now is military. And that's where male pelvic health and men's health has really exploded in my practice. Is the clinic I work at is 20 minutes away from a military base. And so I think that's a reason why the men's health has really blown up my practice quite a bit. Right now, of that 70% number, I'd say over 50% is men's pelvic health and male pelvic health concerns.
Wow. And I would imagine that most people, therapists that were listening, I wouldn't have guessed that. So I would imagine that there seems to be more of a discussion from a women's pelvic health standpoint, I think, in general. So I'm sure we're going to unpack that topic as well. So let's get into the topic a little bit itself. One of the questions that I've kind of asked you already is about the umbrella term. If we could start to maybe discuss this topic in terms of how you might see it in the clinic, and when people are thinking about this topic in terms of like something that might be acute versus chronic or persistent, and maybe the differences as to what that means and how to navigate the healthcare system when that might present to you?
Yeah, so I'm not really sure from a female pelvic or a women's point of view, just because my practice, I've largely seen, men's and male pelvic health. The familiar story I hear with that one is there's a concern kind of through the pelvic floor, whether that's in, some kind of scrotal, testicular, or pain in the penis. And it's super embarrassing to go talk to a healthcare provider about that. I mean, when we look at the literature around male pelvic health, and unfortunately, right now, the literature is reflective of cisgendered men. When they go see a healthcare provider, the number is 84% of that population feels like their healthcare provider should be the ones asking questions around their pelvic concerns. But that's not the case. And so it often it's embarrassing. They don't want to talk about it. And then it kind of gets shoved underneath the rug. And so these acute flare-ups of pain, or these acute pain experiences that this population goes through, they tend to just ignore. And it kind of gets worse and worse until they can't ignore it. And then usually ends up in some kind of hospitalization because they're worried that there's like a testicular torsion or something very serious going on. And so when that happens, they're subject to a bunch of testing and imaging. And in the cases of most of the men that are under my care right now, everything comes back fine. All imaging comes back normal. They can't find anything wrong, but they're still experiencing all this pain. And so the first line in within that population is doctors prescribe antibiotics, and they work for a little bit because antibiotics have an analgesic effect on the nervous system. And so your pain, it dampens or it goes away and you feel really great, start moving again. And then you come off those antibiotics and your pain comes back. And so we get put on the cycle of antibiotics that aren't treating anything, except they're just having kind of this Band-Aid effect on the pain. And so by the time they come and seek help, whether that's from me or from my lovely colleagues, this is turned into something persistent and chronic. And I don't have the privilege of being that kind of first line of intervention. I don't see a lot of that. By the time these individuals come and see me, and it's kind of the same with female or women's health as well. By the time they're coming and seeing me, it's because they've had almost every procedure or intervention done and nothing's working and they can't find anything wrong. So I don't see a lot of acute. I see a lot of persistent and a lot of, I've had pain for years and I'm kind of at the end of my rope.
What do you define as persistent pelvic pain? Do you have do you use sort of a 3 months or more, or?
Yeah. So the actual definition, the gynecological definition, or sorry, not the gynecological, the Association for the Study of Persistent Pelvic Pain, their definition is pain that persists longer than 3 months, that has emotional and social consequences and results in gynecological, sexual dysfunction.
Okay, so inside of 3 months, it would be still considered acute. And one of the things that you're saying is one of the primary reasons why this goes amiss. And I would imagine that for both men and women, it's somewhat similar, is this idea of just being embarrassed to talk about it.
Absolutely. Yeah. And that's more, I'd argue, within the male population, that's kind of more, it's more threatening to talk about it because that's a threat to masculinity when if you can't perform sexually, it's embarrassing to talk about.
So you'd mentioned there about people being put on antibiotics. I'm wondering if you can speak to, because in the population that you're dealing with, you've sort of said they're at the end of the road. They've tried a number of maybe interventions. They've had a number of images done and nothing has quite come up. But there are certainly biological issues that go on in the pelvis that need to be sort of addressed. If you could speak to the differences between those two things, like something like a urinary tract infection that does need to be managed, or any of that stuff, I'm sure the audience would love to hear your thoughts on sort of those two biological causes, maybe of pelvic pain versus non-biological causes.
Yeah, absolutely. And that's a really great point. So if we're looking at the bladder, for example, because persistent bladder pain or bladder pain syndrome or interstitial cystitis has a lot of names. And I think that's one of the confusing parts about pelvic health is that there's a lot of names for the same thing and similar symptoms. So if we're looking at a urinary tract infection, for example, it presents the same way as someone that is living with bladder pain syndrome. There's pain, there's the urgency, there's increased frequency. You might have associated back pain and abdominal pain with it, and even hip pain too, just kind of shows up everywhere. So the key thing with that is if you are put on antibiotics and getting treated for a bladder infection, and you're having more than 3 within a year, that's when you need to sit down with your doctor and have a conversation around, okay, like this isn't helpful. We need to look at perhaps something else. The unfortunate thing with pelvic health concerns is that, when it comes to bladder concerns, it's very much okay, I see. They'll take a culture and they'll look at the bacteria in it to see what's going on and how to treat it. But they're discussing around those midstream samples that you get because they're not actually giving a realistic view of the bacteria that is in the area. So we might actually be treating the wrong thing. And if you're on antibiotics for a long period of time, it's disturbing your gut or your microbiome in the area, which can cause more inflammation. And if you're having any kind of persistent pain through the area, that inflammation is going to upregulate, or it's going to make your nervous system a ton more sensitized. And so that's kind of this cycle of antibiotics that this population may experience when they're trying to get their concerns addressed, is that if there's no presence of a bacterial infection, like in the case of a chronic persistent pelvic pain in men who have prostatitis, 98% of them do not have a bacterial infection, but most of the time it's treated with antibiotics as a first-line intervention.
So can I just get some clarity there where you talked about the 3 times? Is this 3 bouts of pain, or would this be 3 times where there's actually like a positive culture that's found on your analysis?
So it's 3 times where you experience the symptoms of like a urinary tract infection. So if you're, experiencing, pain with urination, any kind of like pelvic or abdominal pain, frequency pain, and then that are very similar to a urinary tract infection. If you experience those and you're treated with antibiotics 3 times in a calendar year or more, you need to be talking to your doctor about other ways to manage this. And if it's actually a chronic urinary infections that are going on.
So in those cases, you're saying the patients wouldn't have positive culture, but they're experiencing symptoms?
Yeah.
Okay, cool. Yeah, I didn't know what the stat was regarding male non-bacterial prostatitis, but it's baffling to hear that 98% don't have a positive culture. And I do know that it is one of the first, not only one of the first lines of defense, but kind of recurrently used. Yeah. And I've definitely, I don't have a ton of experience in pelvic health, but I definitely have seen a few male patients over the course of my practice. And yeah, some of the side effects that they're experiencing from chronic antibiotic use has been pretty substantial.
Yeah.
Well, let's go a little bit further into the men's pelvic health piece, because that seems to be where your practice really lies.
Mm-hmm.
And maybe let's talk about something that you discussed at the top of the podcast, where you were talking about kind of creating maybe an environment where people want to ask questions, or I am the therapist and I'm asking the appropriate questions. Maybe just talk about how you kind of set up maybe your interview process to maybe tease out some of these things that otherwise people are a little bit too embarrassed to talk about.
Yeah, absolutely. And, this isn't just coming from like, if we're looking at anyone coming in with any kind of lower back concern, I mean, just for any kind of lower back pain on our screenings, we really should be asking questions around if there's concerns around bladder, bowel, and sexual health, because that's how we rule out red flags for lower back pain, right? Cauda equina syndrome. If someone is experiencing any kind of acute loss of bladder bowel function, any kind of sexual dysfunction, any kind of numbness in the groin or in the saddles, we call it, and any kind of sciatica type symptoms, like we need to rule those out before we collaborate on a treatment plan with people. So that was kind of my in with pelvic health anyway, was I would just be asking that question when people would come in with lower back pain. Do you have any concerns with your bladder, bowel, and sexual function? And, some people, they kind of shrug it off at first and they go, oh, no, that's all fine. I have no worries there. And then, once you establish rapport with people, they're like, okay, so you asked me this question and I do have some concerns, and, what do you think this means? So it's basically just asking those questions and just asking more open-ended questions. And if they have any other concerns, we just need to play a part in opening the door and keeping that door open to those conversations. And when I was first kind of getting into pelvic health, which was totally by accident, just from me asking those questions, that question to someone was opening the door to a conversation that perhaps they were wanting to have, but they weren't sure how. And with massage therapists, I think, and you could feel free to challenge me here if you want, but as healthcare providers, we are probably the least threatening healthcare providers, and that people really enjoy coming and getting massaged. And whether that's they enjoy the experience of, the touch and the massage itself, or because they have a really good rapport with their therapist, we can make some really meaningful referrals and have some really good conversations around concerns that these people have in a context that is largely not threatening. So that's one potential we hold. And even if you're not, I'm speaking to the therapist now, if you're a therapist that perhaps doesn't have a pelvic focus or doesn't want a pelvic focus, your relationships and your rapport with people, by you creating that safe environment and just asking those questions, can mean that you can just make a meaningful referral that that person can go follow up on.
Yeah, and that's a great point. And I mean, as you mentioned, regardless of whether the person ends up having a pelvic health concern, for pretty much any acute episode of back pain where you think it might be radicular in nature, you should be asking those questions: bowel, bladder, sexual dysfunction. So really, outside of those sort of, I mean, I consider those in my practice to be standard questions that I would ask. And I know that maybe some other therapists may or may not, depending upon the type of population that they see. Is there anything else that you're asking that maybe I wouldn't be asking just based on the experience that you've gained over the years? Or is it just kind of those few standard questions and then open up the door?
Yeah, it's just those few standard questions opening up the door. If I do want to tease something out, and I find, because of my understanding of with men's and male pelvic health concerns, because there's that hesitancy to want to disclose that to a female healthcare provider, that's a population I might kind of tease that out of a little bit more. And for those of you who are maybe they don't know how to do that, I always use the intake form. So things on the intake form that might indicate questioning around pelvic health concerns. If they're on antibiotics is a big one. If they're having, again, lower back pain, any kind of groin pain, if they, and under the digestive section, if they've listed off like IBS, fibromyalgia actually is another one that is really commonly correlated with pelvic health concerns and pelvic pain, kind of your more systemic pain conditions. Those are indicators that I might be asking questions around pelvic health, or a little more specific questions around pelvic health.
And then with respect to men's pelvic health specifically, is there one prominent concern that you're seeing? Or I'm sure there's a variety of things. Is there something that you're overwhelmingly seeing in your practice? Is it pain? Is it pain and dysfunction? And speak to that a little bit.
So yeah, the number one reason is pain. And then it's the dysfunction that follows from it, right? And whether that's erectile difficulties, if there's urgency with urination or bladder pain, even sitting for long periods of time is another one with that population. If they're experiencing any kind of pelvic floor concerns, work impact. I mean, when we look at, there was a questionnaire done in 2019 by Thomas Astill, and he sent a survey out to 30,000 men. And that included not just straight men, but homosexual men as well, which was really awesome because that's kind of the first time I've seen that population of men represented in research. The number one concern that they had with their pain was their mood. They hated the way it impacted their mood. And when we look at other things on that list, it was like, number two was their ability to work, their ability to engage in sports. And then a little further down, number 6 came in was mistrust of a healthcare professional. And that one was written in. That one wasn't even an option on the survey. But that was such an impactful and, I guess, similar experience between those who took part in that survey, that they took the time to write it in the survey, that they had a mistrust of a healthcare professional. So again, when I'm looking at an intake form and I see that, there's multiple activities impacted, work's impacted, sitting for long periods of time is impacted, they're on antibiotics, they might have been diagnosed with a generalized pain condition, I'm probably going to be asking more specific questions around pelvic concerns.
For men's health, is it you're seeing the same type of scenario over where the patient is experiencing, let's say, testicular pain, for example, and they've basically got a negative urine culture and they've been put on antibiotics for just 3 or 4 or 5 times. And then that's sort of where their buck stopped. Maybe they've been referred to a urologist for some sort of procedure, and then they're just like, there's nothing we can do. And that's sort of what they've been told.
Yeah. And it's embarrassing. I know in the in my practice, so my experience, I can't speak to everyone here, but going and getting like any testicular imaging done is super embarrassing, because here, from what I've heard, there's no male ultrasound techs. So they have to go to, a female to get this done. And the concern is, well, you don't have the parts, so you don't know, and they're already in pain. They're already sensitive and they're in pain. And now they have to have someone handle these, sensitive parts by someone that isn't familiar or doesn't have those structures. And so the concern is, it's embarrassing to have a female scan and look at, such an intimate area, and then handle it in a way that perhaps might be more painful for them. So they'll put off imaging for that reason here. And that's something that we need to address.
Well, yeah, because, speaking back to the acute stuff, there can, in cases of a lot of pelvic pain in both men and women, there can be some things that need to be managed quickly. And there certainly are red flags. And so, we do need to do a better job. I would say that it's probably similar in Ontario, where the majority of, and again, I'm just guessing, the majority of ultrasound techs probably are female. So what do you think, outside of maybe just opening up the conversation, are there anything else that we can do in our practice in general to try and help facilitate opening up a conversation between both men and women, or practitioner and patient, to help get ahead of this a little bit earlier?
Yeah. Well, I'm not sure what it's like over there, because here, especially in Victoria, there is I'd argue, a shortage of massage therapy here. And when you look at my wait list, I think yesterday my wait list was like 54 people waiting to get in for massage. So
you must be doing well out there.
Apparently, yeah. But again, I can't speak a lot to the acute, because I rarely see it. Actually, I'd argue I never see it, because to get a massage appointment is about a 2-3 month wait here, as is, I feel that's very similar to our healthcare system in Canada, is that when you're waiting for, a specialist appointment, it's at minimum a 6-month wait. Any kind of imaging, it's a wait. And so by the time we can come in and provide some intervention, that acute phase is over most of the time.
So just a kind of an aside question, of all pelvic pain then, in men or women, or men only, based on the research that you've read, do you know what percentage we might be able to theorize would need something like an intervention? Is bacterial, needs urology, needs surgery, or some sort of less invasive procedure? Do we have stats on where that might sit in sort of all global pelvic pain suffered, and 5% is sort of more acute, needs to be managed procedurally, or we don't really know what that is?
That's a good question. I don't really know what that is. I know and I think it's just if we're looking at male-female pelvic health, male health tends to go underreported. So I'm not even really sure those numbers would be accurate, because I've read certain urology journals and I've gone, well, that doesn't speak to my experience and my practice at all, with some of the numbers that they've listed. And if we're talking about female pelvic or women's pelvic concerns or pelvic pain, I think it's just because a lot of those concerns come with postpartum. It's almost, and because of the access to pelvic floor physiotherapy that has really done a good job in getting its name out there to help support that population, there's more outlets for that population to help get their concerns managed. But when you look at anything outside of that postpartum population within the female pelvis or female pelvic health, like if you look at things like endometriosis, for example, is, I would argue, very poorly managed, because they just don't know how to manage it. And it goes underreported because in order to have a diagnosis of it, you have to have surgery. So
yeah, and I also wonder, outside of that I wonder then if the statistics are being skewed because some of that pelvic health stuff's being lumped in with the postpartum stuff, and it's not giving a true picture of what's going on. I would wonder as to whether it would be different really than anything else. Like if you look at back pain or shoulder pain, and we look at, sort of the small percentage of incidents of things that require procedures like surgery or that type of thing. I don't know that it would be any different. That's probably something to keep in mind, but I think that you're right. I think that opening up the conversation from a therapist-patient relationship allows people to get ahead of these things if they are serious and not put them off. And then, as you said, if in fact they do come back as non-red flag in nature, then you've already established that relationship, and then you can formulate a treatment plan around, trying to achieve best outcomes for the patient.
And if I can expand on that red flag a little bit and just talk to perhaps some of the therapists that are listening right now.
Yeah, for sure.
We, as massage therapists, because it's often the case, people are coming to you and they've had all the imaging, all the testing, they've had everything done. And that can sound really scary too. And we don't know what role we play. But I hope I can, pass on a little bit of advice here is when I hear that, when someone comes in and they tell me, I've seen 11 specialists, I've had these procedures done, they can't figure out what's wrong with me. The hard work is done for me. They've been ruled out for all their red flags, which means they can come to me and we can explore some movement, explore some touch. I can provide some education for them there. Perhaps we need to explore some breathing to help kind of down regulate that nervous system to address the pain. Because if you think about it, how stressful is that going through all the specialist appointment and being told that there's nothing wrong with you, but you're still in pain. So our role is really important just to validate the person in front of you. And if you don't know how to help this person, make a meaningful referral. But please don't be, scared to say something or validate someone, because this population so desperately needs help. And if they're having that conversation with you, please make a meaningful referral if you don't know how to manage it, but don't be scared of it either.
Yeah, that's a really great point. You spoke there a little bit on exercise. Do you manage a lot of that in your practice? Do you co-manage it with the physio?
Her and I treat very similarly, with the exception of the internal. And because that's out of my scope of practice for those listeners who aren't familiar with massage bylaws. But she doesn't she doesn't do internal massage. Like she doesn't do trigger point release. The only time she does internal work is really to give a lengthening or relaxation cue through the pelvic floor musculature. And that's with more recent research that's come out, actually out of Ontario, interestingly. We're discovering that with female pelvic pain, 95% of it is actually because of a pelvic floor dysfunction that comes from like the lengthening aspect. So we've got like that contraction under control, but it's the relaxation or the lengthening of pelvic floor musculature that's not being addressed. And it's contributing to pain in the area. So the only reason she'd ever do the internal is to help with the relaxation. And as a massage therapist, my bias here is that I'm really good at helping people relax. So the way we address it is a little bit different, but the messaging is the same.
I've heard of this. I didn't know I didn't know the stats were 95%, but let's circle back and maybe explain that to listeners that might not have a therapy background about, just so they're sort of aware with some of the therapies that are available, what would internal therapy mean?
Okay.
And then also even with respect to, because pelvic floor is a word that is thrown around so much, and even the word pelvic floor dysfunction. And one of the things that's often discussed and used in light of pelvic pain is Kegels and sort of variances of that. Yeah, just give your opinion on some of that stuff and how you see that, I think would be really valuable.
Yeah. So what comes to mind, and I don't know about any other listeners here, but whenever I hear the term like Kegels thrown around, I always think of like this, I forget what movie it's from, but this woman is like sitting on a couch and she's got like her headband on and her workout gear. It's like an 80s movie. And she's doing a workout video and she's like gripping the couch like super tight, doing like these Kegel exercises. And I think that is the imaging that maybe some of us have about like pelvic floor conditioning, is that it's always this contraction that needs to happen. And when we think about, if we're looking at nervous system involvement and pain there, we have these defensive or these protective mechanisms in place, right? So if you take, maybe we'll take another area like the upper trap or your kind of neck and shoulder region, because that's commonly gets treated in massage, and it's threatened, it's going to maybe present with some tightness, right? And we're going to have lots of range of motion. We go in there with massage, kind of relax it, and then, we might have an increase of range of motion and a decrease in pain. With pelvic floor, it's kind of similar. So if you're always contracting it and it is angry and irritated and you're loading through it when it can't handle these loads, that's not going to help it feel better. And I'd argue it's going to make it feel more cranky, and it's going to amplify some symptoms that you're experiencing through the area. So when we're talking about lengthening the pelvic floor, we're talking about being able to kind of relax it and allow some more tissues to stretch, if you want to use that terminology, stretch sensations, so that when you're contracting, you can actually generate more of a force from like a lengthened state to a contract state. So I'll use a metaphor here that I use a lot with my patients is, if you think of a jellyfish, right? And how it propels itself forward, it kind of contracts and relaxes, right? There's it comes together, it compresses, and then it relaxes and compresses and relaxes. If that jellyfish was your pelvic floor and it's always contracted and it's only being able to generate force from a contracted state, it's going to kind of fall towards the bottom of the ocean, right? We're not going to be generating force to propel forward. So the strength actually comes from the length. It doesn't come from the contraction.
So it might not be about Kegels and core stability. It might be about quite the opposite of that.
Yeah, exactly. And so when you emailed me before about we were kind of collaborating on some talking points, and you mentioned about when abdominal strengthening would actually be indicated, that's actually a point I wanted to talk about, because if we are dealing with someone that perhaps is experiencing like a pelvic organ prolapse, by doing core exercises, you might be overwhelming the pelvic floor with a intra-abdominal pressure that it cannot handle. And so we really have to be thinking critically about, when abdominal exercises would be indicated and why we're doing them, because you don't want to be prescribing someone core workouts when they do not have pelvic floor that can handle that load.
Yeah. And for those people that are listening that haven't quite maybe gotten what the pelvic floor is, it's the floor that's supporting the bladder. Could we just say that? Yeah.
Yeah, it's the diaphragm, if you will. So if you're thinking about anatomical terms, I probably should have explained this before. It's really the area between like the pubic bone and the tailbone, and then your two sit bones on the bottom of your pelvis.
Are there circumstances where you think core stability is indicated? And if so, where? What are those circumstances?
It's really person-centered. So if you're dealing with, perhaps, I don't see this a lot with men's or male pelvic health, because the core strength is usually there. It's actually getting them to relax that's the issue. But if we're looking at a postpartum pelvis, for example, and perhaps if we have like a diastasis recti abdominis present, again, why you really being critical about why I would be giving any kind of abdominal exercise for that. And it's not because I'm trying to like close the gap, because what the research is saying now is, that might not be possible for a majority of individuals that have that, but it's about being able to re-engage that linea aspera and generate contraction through it. So again, baby steps, right? And that's one of the things we have to be careful of with a postpartum population or a postpartum pelvis, is that DRA is really, really a way of like letting pressure out of the abdomen when you're pregnant. So it's a very normal process that happens. And as healthcare providers, I feel like we might be a little guilty of making that pathological when it's actually not. It's normal. It's just something that maybe we need to work on some coordination and strengthening around to help that person adapt to those changes in the area.
Yeah, that's really great information. I think that taking the person-centered approach and not allowing people to always prescribe core stability or always prescribe a Kegel exercise when what the research is suggesting now is it might, in a lot of cases, be more of this sort of relaxation-based stuff that needs to happen. Speak to that a little bit, and what are some things that you use in your practice right now, either movement-based or cueing-based, or other maybe tools that you're giving the patients to help sort of facilitate calming down the nervous system or calming down that area of the body?
Yeah. So if I'm calming down nervous system, I usually use breath work first, because if we're dealing with someone like a postpartum pelvis, for example, using breath is actually really, really good because it's relaxing. But if we are dealing with like a DRA, for example, or even a pelvic floor sensitivity, or if we're trying to build a pelvic floor tolerance, breathing is a really good way to do that because the person's in control of like how deep their breath is. But it also helps kind of gradually load these structures again, which is what we want, right? Graded exposure. So the first thing I'll use is some breath work, and maybe we'll work on some engagement of those abdominal muscles if it's indicated for that person and if it aligns with their values and their goals. So that's kind of step one. And then step two, I might get them to do some stuff where they're moving the limbs off the table on their back or in a supine position, and just seeing if we can get some engagement going on through the core, and how easy that is for that person. And if it's not, then maybe we have to back off a little bit and work on some more cueing. If I'm working with the pelvic floor musculature, I usually get them into a quadruped or on your hands and knee position, and just getting you to sit back towards, your sit bones to your heels, and working with breath again, right? And really focusing on feeling that lengthening that's happening through the pelvic floor is another good one. That's kind of where I start. And then it just depends on how that person's presenting and what they like, and then just kind of going from there.
Is with the engagement stuff that you're using, are you always coaching the breath consistently to kind of breathe always in abdominal? It sounds very DNS like, I guess.
Yeah. It's actually, it's kind of similar, but it's just the narrative is different.
Yeah, that's one of the elements that I have kind of always not necessarily taken it from them, but I think that's a really great thing to encourage patients to do, because so often with the core stability stuff, you see people just like hold their breath all the time. Yeah. And one of the lines that I like to use is, you have no business doing core stability work until you can own your breath first, and then own it in some of these sort of lower threshold positions, and then gradually progress there. So that sounds like we would do a lot of similar stuff there. In terms of your treatment that you might offer people in the clinic, are there certain body regions that you find yourself working on more? Are any of those maybe outside of somebody that doesn't have a special interest in this? Like, do you work more on the abdominals, for example?
Good question. I mean, I feel like we're all, at least I can speak to BC because I'm familiar with the programs here, but we're all taught how to do an abdominal massage. I mean, that's term 1, term 2 kind of stuff. So I'm usually treating like pretty close or on top of the pubic bone, and then high groin kind of stuff, and then around like the sit bones or the ischial tuberosities, if you want to get fancy. That's kind of like the boundaries of where I treat. And actually you can do a lot, because the techniques I do, if you want to call it visceral or DNM, or it looks like that, where I'm just providing like a stretch through the area in a way that feels good. And then getting that person to, okay, I want you to focus on like, you feel that lengthening that's happening through the pelvic floor, or whatever language that they're comfortable using. That's what we're trying to find with our treatments. So I might play around with the groin, the really low abdominal, or even around like the sit bones, to try to get them to feel that stretch sensation that's happening through the area.
I know this is going to be kind of a random question that you're not going to have maybe the greatest answer to, but what has your success been like in using the treatment? And like, have you been able to, I don't even know how to ask it, but what's your success been in treating persistent pelvic pain?
So I'm actually really happy that you asked this question, because this is something I was talking with my pelvic floor physiotherapist about last week. And we were talking about, so we kind of sat down and we were eating lunch, and I just kind of said, do you find that you're able to, like, you don't see your persistent pelvic pain as often as like your regular type, like non-specific back pain and neck pain and shoulder pain patients. And she's like, yeah, absolutely. And I'm like, okay, great. Because on average, I maybe see them 3 or 4 times. And then they have strategies to help manage their pain at home. And, they don't come back, which is great. Because I find I'm actually able to discharge people that are coming in with concerns in those areas versus, something like non-specific neck pain and shoulder pain, like speaking to my practice anyway, those are people I'm seeing for sometimes years. Mm-hmm. And we were kind of discussing, and maybe you can want to provide some insight here as well, but we were kind of playing around with why that might be when we're talking about a non-specific shoulder or neck or lower back pain, why these people are coming in so much longer than our pelvic health or our persistent pelvic pain populations are.
Yeah, I don't have a great answer for you there. Yeah, it could be the nature of what they went through, and the fact that they saw somebody that was able to kind of provide them a great insight to treatment, that, maybe the fact that it is more persistent pelvic pain, it's perceived as more debilitating because of as we've discussed, some of the embarrassment about it, and the fact that it's maybe taken them so long to get some validation or some help or some strategies. Yeah, that's probably the thing that, I would say would jump out to me. Maybe it's being managed by the therapists that are managing it from a more holistic approach, because the education is progressing and the people that are looking at it from sort of a total evidence-based perspective, you really have to come to it from that lens and manage it from that way, and really treat the patient as a whole. Maybe, one of the things that because a lot of my practice is concussion-based, one of the things that is a predictor for more drawn-out prognosis for concussion is if the patient's experiencing dizziness or experienced dizziness at the time of their injury. And we don't know if that's because dizziness is a difficult symptom to manage, or we suck at managing dizziness. Mm-hmm. Right. So it's sort of that, are we as therapists just more okay with the person coming in for the traditional shoulder treatment? And then you could also ask the question, are patients more comfortable coming in for the more traditional shoulder treatment than they are the pelvis? You could ask it the other way around. I don't know. I don't really, as always, I don't have the answers, but I think it's definitely something worth thinking about, and trying to get those more long-term outcomes, or helping people or ridding people of their persistent pain, I think would be amazing as well.
Yeah, I totally agree. I think too, and this is what we were talking about, I was talking about with my pelvic health physio, that when you're dealing with someone that has like a persistent pelvic pain in the area, there's a visceral component to it usually. And so it's like the urgency of trying to get this managed, quicker plays a factor there. Mm-hmm. And if you look at the evidence for, pelvic floor interventions and pelvic floor physiotherapy, it's like level 1 grade A evidence. Like, it's the best for some of the interventions that are used, versus I'd feel like some of the lower back and neck and shoulder, because there's maybe a lack of some kind of visceral involvement there, that's why it takes a lot longer for these issues to resolve. And I think too, it's sometimes, again, it's just the language and the narratives that we're telling people when they're coming in. Like, we're more often to perhaps make things sound a lot scarier than they really need to be. And I feel like that might be playing a role in some of the long-term beliefs that I'm having to not directly address with people that are coming in with concerns in those areas, but I'm having to give them permission and show them they don't have to be scared to move more than I am with a pelvic floor concern.
Sorry, did you say you think you have to give the pelvic floor person more permission to move?
No, the non-specific pain, like the lower back and the neck and the shoulder, like I
Oh,
have to give
really?
them more permission. It's okay to bend over and your back's not going to fall apart.
Yeah.
It's okay to turn your head and, you're not going to dislocate your neck. And I think it's just because it's the pelvic floor, and that's kind of like where I see a lot of potential with pelvic pain, is that because it's an area that perhaps it's not a common thing to see in practice, that there's just less kind of noceboing or less, scary stories being told about what's going on through the area, because it's not a common intervention offered in musculoskeletal health.
Do you think part of the reason that may also be is by the time the patient gets to you and they've been through the gamut of imaging, this, that, and the other thing, there is no more fear from a structural or a red flag standpoint? And then when they get to a practitioner that's well versed in it, they're kind of like, oh, okay, now I can just like listen to this practitioner and have them give me some strategies, versus something like a neck or a shoulder. A lot of people can just be like, well, this is sore, but I can deal with this.
Yeah.
But it's not, like you said, maybe it's not as debilitating to the rest of their life as this particular issue. So once they get to somebody that's able to help them, it's like, yeah, I'm on board.
Yeah.
Let's do this. Yeah. It's really interesting points you raise there.
Yeah, it's just, and I don't mean to spring that on you, because that's, as someone that is finally working alongside, someone else that helps manage this population as well, these are things that we are noticing that just aren't necessarily reflected in the research right now. So I think these are important conversations to have, but until we actually can see some kind of research that comes out around them, it's good to explore.
I think we've talked about a number. I think you've given people, and both listeners and therapists, a number of different tools. But do you have any other suggestions for how therapists can better, if they're interested in pursuing this as a special interest, how they can better set them up themselves to incorporate this more into their practice? You've given a lot so far, but if there's any sort of closing thoughts.
So are you talking about like marketing themselves as a pelvic health?
Whatever you want, really, like whether it's marketing, whether it's truly helping people, whether it's a particular researcher that you feel like they need to look at, whatever you want. If this is somebody that's been considering, I'll give you two questions. If there's somebody that's considering making this part of their practice, and then speak to maybe the listener that's struggling with something going on that hasn't quite been helped, and maybe how they can navigate the healthcare system on their own behalf to try and help find them somebody to help with their persistent pelvic pain.
Yeah. So if we're taking the therapist question about just if they're wanting to get into the world of pelvic health, my first thing is, what you're hearing me talk about is about 6-7 years that I've put into researching and continuing ed in order to help manage this population. So don't feel like this is, a huge mountain from just based on what you've heard from this podcast that you have to climb. Take it little bit of chunks at a time, right? As perhaps you dismantle some narratives, know what perhaps you're going to replace that with. I know in the massage therapy world, the only real introduction we get to anything pelvic is visceral manipulation. And that's where I started. So I can't hate on it. And if you're someone who perhaps just isn't comfortable, touching or treating through the areas, like by all means, go take a visceral manipulation course. I'm not saying that, it's bad. It feels really good. But we just have to be mindful of some of the narratives that are being perpetuated in that community that perhaps are not helpful, that we need to be aware of, and make sure that we're very careful with how we're wording things to patients that are coming in to seeking our care. That's where I would start, just getting more comfortable with, first off, asking questions around, bladder, bowel, and sexual health, and just knowing that you don't have to address those, in your during your treatments, just asking the questions and then making a referral or having a conversation perhaps around maybe their concerns and validating their concerns is step one. And then just be brave. If this is something that you are really passionate about and you just don't really know where to begin, start with an abdominal massage. It's been a while since we've done those. I know prior to visceral manipulation, like it was that half sun, full moon or whatever, like abdominal technique it was. So, just really be brave and really try to, understand your capacity as a therapist, but always try to nudge that boundary. That's how I was able to experience a lot of growth with my practice and how I treat that population. And then if we're talking marketing yourself, go to clinics. I can't tell you, when I moved here to Victoria, I went to, there's a sexual health clinic here. There's a bunch of like prenatal, postpartum, gynecological clinics here, urology clinics. Like I just went in, had a letter, introduced myself to the doctors and just let them know what I was about. And I got tons of referrals. So that's another way if you're passionate about helping this population, and we really do need more therapists to help with this population. Those are kind of or suggestions I'd make there.
Well, and you raise a good point, because there are plenty of therapists that treat low back pain, and there are not a lot of therapists, especially in the massage world, that are treating pelvic pain. So I can guarantee you that letter probably went a really long way for you in building your practice.
It did, yeah.
Yeah, I can say I haven't done I've never done an abdominal massage in my practice by virtue of the people that I see, but I still know what full sun, half moon is. As literally probably every other massage therapist on the planet is also familiar with it. What about for the patient that's maybe struggling with something persistent? They've heard the scenarios that we've discussed, where maybe they've been given antibiotics over and over and over. They're not really getting any resolution or answers. Mm-hmm. Any advice for them?
I'm going to bring it down to, and this is what I tell all my patients when they go seek healthcare, is important questions to ask your healthcare provider. And I always refer back to Gifford's 4 questions of what's wrong with me? What can you do to help me? What can I do to help myself? And how long is this going to take to resolve? So asking your healthcare provider those questions is going to give you some insight as to, if this is someone that might be able to give you an idea of what's going on, and ask more questions. Like, I always empower people who are listening from the person perspective, the person living with persistent pain. Ask questions and ask uncomfortable questions, because as therapists and as clinicians, we need to be able to answer those questions, and we need to be challenged in that way. If you're someone who is struggling with persistent pelvic pain and you're not finding kind of every route has been, or every path has been unhelpful, or you don't feel validated in your experience, my suggestion would be get a referral to either maybe pelvic floor physio. I'm not really sure how it works in over there, but get a referral to, whether a pelvic health physiotherapist or, maybe a massage therapist that has some kind of focus in pelvic health, to get the aspect of perhaps just some cranky tissue that needs to be relaxed, addressed, instead of more invasive procedures that perhaps are leading nowhere.
Yeah, that's a good point. I think for a lot of people that are listening in Ontario, and again, Jocelyn and I can only really speak to Canada, but I know we've got other listeners in other countries, but it appears right now that pelvic floor physio seems to be a decent sort of entry point into the world of complementary healthcare that can help you at least start to navigate that system if you're not getting any answers from your family doctor or some of the specialists that you've been seeing currently. And I would imagine, based on the growth of this, that there are many urologists, GPs and stuff that are starting to make those referrals, as that stuff doesn't manage itself on its own. Yeah.
And on that note too, for people who are listening that are living with, persistent pelvic pain, or really any persistent pain, you're always in control, and consent is a big one. And this is something I talk to clinicians and people about. It's an intimate area, it's a sensitive area. don't feel like you have to do something in order to feel better. And I know some of the interventions out there right now for pelvic health are, needling through the area and like invasive internal trigger point treatments. And if that works for you, absolutely great. But always know that you're in control and you have consent, and that you can use your consent to dictate your treatment and what you're comfortable with. So please don't feel like you have to subject yourself to something uncomfortable and something you perhaps don't want to do in order to feel better. There are ways around. There's always modifications we can make in musculoskeletal health. Just ask your healthcare provider if that's the case.
Yeah, a really important piece of advice there. Just because it's shown to work, it doesn't necessarily need to go that way for you if you're not comfortable with it. Jocelyn, do you have anything else you want to talk about or add before we kind of close up here? This has been really great. What about where people can find you?
That's a good pointer. So I'm working on a website right now. It's not up yet, but it's thepelvichealthrmt.com. And you can find me on Facebook. I am Jocelyn Delorme on Facebook. And if you like funny videos, creep my page. I got some really funny ones about, the clinician point of view about managing persistent pain. And you can find me on Instagram at Jocelyn Curtin RMT.
Cool. Well, I think this has been a really valuable conversation. I think there are going to be a lot of people that learn a lot from this. So thanks very much for coming on. If you have any questions, folks that are listening, for Jocelyn or myself, feel free to leave them in the comments below. As always, folks, I hope that you found this episode to be of value to you. Have yourselves a great weekend, and we will see you in the next one.